So we'll call the next presenter, Dr. Saumika Singh, for her presentation.
Dr. Dipali Gawai is ready. Okay, and Dr. Anshul Garg. Okay, fine.
Good evening all. I will be presenting on epibulbar complex choristoma with systemic association. So like we know, choristoma is a benign congenital lesion containing histologically normal appearing tissue in an ectopic location. Epibulbar choristomas are lesions in bulbar conjunctiva which can either be simple, containing tissue from one germinal layer, or complex, that is containing tissue from more than one germinal layer. Epibulbar choristoma is considered a rare condition, though it is the most common type of epibulbar tumor. Most complex epibulbar choristomas are known to have syndromic associations. So my case is that of a 12-year-old female child who complained of fleshy growth in the left eye since birth, which was gradually increasing in size for last 1 to 2 years. She had no known systemic illness and had no similar family history. On ocular examination, we could see soft vascularized epibulbar masses at 2 distinct lesions, superotemporally and nasally. The superotemporal lesion extended from 11:30 to 3 o'clock hours, 12 into 10 into 3 millimeters in dimension, crossing the limbus and involving 3 to 4 mm of cornea. The nasal lesion extended from 11 to 9 o'clock hours and was 10 into 7 into 3 millimeters, involving 1 to 2 mm of cornea. On further examination, we could see thick and firm subcutaneous lesion on the left upper eyelid middle third, which had increased hair follicles. Similar lesion was noted in left frontotemporal area and lateral third of the eyebrow. However, the hair follicles were of normal numbers. Her best corrected visual acuity in the right eye was 6.6 and the left eye was 6/36 with plus 3 diopters spherical and minus 2.5 diopters cylindrical. The fundus examination was within normal limits, suggesting that the left eye had gone into amblyopia. On further investigation, the MRI orbit revealed an arachnoid cyst along the left anterior temporal convexity. After getting pediatric and neurosurgery clearance, the patient was planned for excision biopsy plus minus amniotic membrane grafting under general anesthesia, and the samples were sent for histopathological examination where the superotemporal mass revealed a glandular structure with multiple lobules, acini with ductule suggestive of ectopic lacrimal gland. Along with it, it also contained fatty tissue and hyaline cartilage, hence the superotemporal mass was that of complex choristoma. The nasal mass consisted of keratinized stratified squamous epithelium, loose stroma, and blood vessels, suggestive of a fibroepithelial polyp. So with the features of epibulbar complex choristoma, arachnoid cyst, and cutaneous lesion, the child was flagged as a case of organoid nevus syndrome forme fruste. The following picture is a post-op den visit where the healing is still in process. The patient was also advised patch therapy to recover from amblyopia. So going by the literature, epibulbar choristoma has a reported incidence between 1:10,000 to 1:30,000, limbal dermoid being the most common type and characterized by well-circumscribed keratinized dome-shaped limbal mass. Complex choristoma has diverse clinical presentations, including circumferential or isolated epibulbar mass, limbal tumor with corneal involvement, lateral canthal mass, or eyelid mass. Management depends on extent of involvement, risk of amblyopia, and cosmetic concerns. Those epibulbar choristomas with syndromic association, when examined histopathologically, have been found to be complex choristomas. Jadoso has been credited for introducing the term organoid nevus. The term linear nevus sebaceous syndrome and organoid nevus syndrome have often been used synonymously. Because of the nature and distribution of its associated ocular, central nervous system, cutaneous, and systemic lesions, the organoid nevus syndrome appears to have similarities to the oculoneurocutaneous syndromes or phacomatoses. Neurological manifestations associated with these are mental retardation, seizures, and arachnoid cyst. So my take-home message would be it is important to differentiate the various congenital epibulbar lesions like choristoma, vascular epithelial, or lymphoid origin tumors, since complex choristomas have syndromic associations and can have greater implications. The idea is to look beyond the eye, and the management is to prevent amblyopia and provide good cosmesis. These are my references. Thank you.
What is the longest follow-up we did?
So the patient has been followed up till 9 months now, and the recovery is well. Amblyopia has not improved much, but the patient surface-wise is doing good.
No recurrence?
No recurrence, ma'am.
So if on histopathology you're finding a lacrimal gland tissue, that means that you have traumatized the lacrimal gland. It's not the ectopic lacrimal gland. You mentioned in one case, no?
No,
so
no,
I'm
it's
just
ectopic.
highlighting.
There are many literature reviews where the complex choristomas often contain ectopic lacrimal glands.
So supratemporal was the lesion, no? So
Yes,
most probably it was the, the normal lacrimal gland. How otherwise you will differentiate, So complex choriostomas generally have calcification, ossification, and in a supratemporal lesion, taking out, debulking it, if you are getting lacrimal gland tissue, that is what we first think of.
Okay.